I'm Sean Sternberg. I'm a chief here at OHSU, and my study was done at the VA looking at whether or not we could use expired air carbon monoxide testing to screen for smoking status in veterans. It was a prospective pilot study of 70 patients. I have to say thank you to Dr. Yu and our department for giving us a grant of $5,000 to purchase the machines to use for the study. We've been wearing masks for the past year and a half, and they wore masks about a century ago, and someone was clever enough to invent a mask that you could smoke through, thinking that maybe it would kill the impurities and keep you from getting the influenza virus. So maybe this will come back and keep us from getting coronavirus. So background, cigarette use, it's disproportionately higher among veterans. There's more smoking. It's about 27% in some studies. And because of this, we need to be cautious when treating our veterans and selecting them for surgery. Because there's a high risk of postoperative complications associated with smoking, such as wound complications, surgical site infections, pneumonia, as well as one-year mortality. We call this smoking status misclassification. It's when a patient says they're not smoking, and then we have laboratory tests that say that they're nicotine positive. Typically, we obtain smoking status through a self-reported questionnaire. You can just simply chat with the patient in clinic and ask if they've had any smoking history. The problem with that is that this leads to misclassification in about 23% of ex-smokers because they may underreport. So the way that we test for this, kind of the gold standard, is a serum cotinine test. It's a blood test that it tests for a metabolite of nicotine after it's processed in the liver. You can also test for this in the urine, as well as exhaled carbon monoxide testing, which is essentially breathing into a machine that can detect carbon monoxide. And these are all different methods to test for recent smoking status. Now, as of 2017, the Oregon Health Authority banned any elective surgery for patients who are currently smoking and required that anybody who has a smoking history demonstrate smoking abstinence for 4 weeks prior to surgery. And they list a few different tests, but of note, both cotinine and exhaled carbon monoxide were tests that they listed as being acceptable to demonstrate smoking abstinence prior to surgery. So exhaled carbon monoxide testing, it's actually been around for about 40 years, although it's pretty scant in any orthopedic literature. There's been several studies in the past couple of years that have noted use of it. What it is it's a breathalyzer test that detects carbon monoxide, and carbon monoxide it's produced from organic combustion, burning a cigarette. We do know that breath carbon monoxide levels above 6 parts per million is a clinical marker of recent smoking. The nice thing about this instrument is it provides immediate results in clinic with point of care testing. Although it has limitations, it only detects recent smoking status, and it can be falsely elevated in respiratory disease. One benefit of this, we know that preoperative smoking cessation interventions, they've been shown to decrease smoking rates the day of surgery and promote abstinence 30 days post-operatively, which is important during the healing period. And then the other point to note is that with smoking cessation, we often use nicotine replacement therapy. And this carbon monoxide breathalyzer allows for differentiation between a nicotine replacement because it doesn't test for nicotine. There was a study that came out in 2019, the OTA published using this exhaled carbon monoxide monitor. And I just wanted to point out that they showed that use of this increased willingness to quit smoking, and it also increased referral to the National Quit Line. So whether or not it makes any other difference, it gets people to call the quit line and increases their willingness to quit smoking, according to the study. I just wanted to point out that because this monitor has been around so long, it's been well studied. And there's several studies that show that a cutoff of about 6 parts per million can differentiate someone who's smoking versus someone who's not smoking. So this is a chart from a publication in Respiratory Medicine looking at the carbon monoxide parts per million levels on the left here in healthy smokers compared to healthy non-smokers, and then passive smokers. And then on the right, showing the cutoff line differentiating between the two. There's also a correlation between how much you smoke and your exhaled carbon monoxide level, and the heavier smokers tend to have higher levels. And then the test is not perfect. It can be confounded by patients with asthma, COPD, or other lung diseases because it is testing for carbon monoxide. And patients with lung disease, if they're around secondhand smoke, may have higher levels of carbon monoxide. So this was a single institution prospective cohort study done at the Portland VA of adult orthopedic patients in pre-op clinic. We collected self-reported smoking history, serum cotinine, and expired carbon monoxide levels. The study duration was meant to go for about 2 years. It was stopped early due to the COVID-19 pandemic. We didn't want people breathing into these straws with a pandemic going on. Our objectives were mainly to see if we could use this as a screening tool in pre-op patients. So we wanted to compare it to the reference standard, which is serum cotinine. We wanted to compare it to self-reported smoking status. And then we also wanted to evaluate the cost difference between this and a serum cotinine test. We hypothesized that it would be non-inferior to serum cotinine testing. It would allow for differentiation of nicotine replacement therapy as compared to a serum cotinine test. And then we thought it would also be much cheaper. We published our protocol prior to patient enrollment and had all of our plans in place for how this prospective study would work. We planned and eventually did collect the questionnaire, the serum cotinine and nicotine assay, as well as the exhaled carbon monoxide test on the first visit and or second visit. And then we aim to collect exhaled carbon monoxide on the day of surgery. And in about 16 patients, we did collect this and blinded those results to the surgeon. This was our questionnaire. It essentially looked at patients' smoking habits, whether they were smoking daily, weekly, monthly, yearly, when was their last cigarette, how much did they smoke usually, how long have they smoked. We also looked at other forms of products smoked or nicotine used. So looking at nicotine replacement therapy, gum or patches, cigars, chewing tobacco. And we also included marijuana and e-cigarettes. And then we also collected whether or not they had any type of lung disease. So we also performed an a priori power calculation with an estimated sample size of 250 patients, even though we didn't reach that. Again, our main 3 points of data collection were the self-reported smoking, serum cotinine, and exhaled carbon monoxide levels. We used cutoff values for the serum cotinine and exhaled carbon monoxide based off of recommendations from the Society for Research on Nicotine and Tobacco Treatment Research Network. And after these data were collected, we divided our cohort into current smokers, those smoking daily or weekly, and non-current smokers, those not smoking or smoking very rarely, like a monthly or yearly. Our inclusion criteria were essentially adult patients that were indicated for surgery. We excluded patients who essentially were not able to consent because of an injury, or they were intubated or sedated. And then we had listed, at least in the IRB, that we would exclude prisoners or pregnant patients, but we ended up not having any of those. And one more thing, we also excluded patients who were treated non-operatively. So we had 70 patients recruited into the study out of 160 eligible patients. And then of these, due to some incomplete data, our cohort got narrowed down to 55 patients. We had 14 non-smokers, 36 ex or yearly smokers, and 5 current smokers. And this pie chart just lists the percentage of the population for each category. In terms of smoking habits, on the right is the current smoker group, and then on the left 2 columns are the never smokers and ex-smokers. You can see that of the quitters, 16% of them quit less than 1 year ago. Otherwise, the rest of them quit between 2 and 5 or greater than 5 years ago. Of the smokers, they were smoking 1 to 4 cigarettes, 1 patient, less than 10, 2 patients, and then between half and 1 pack per day, 1 patient. The never smoking group, you can see down at the bottom, 3 of these patients were using marijuana, so they were actually smoking a combustible product, as well as the ex-smoker group. 8 of them were smoking a combustible product. You can see down at the bottom, smoking marijuana. In the ex-smoker group, there's also some patients using nicotine replacement therapy, chewing tobacco, and cigars, so other nicotine products. And then as well in the current smokers, there was 1 patient smoking marijuana and 1 patient smoking e-cigarettes. So quite a variety of different products being used. The most prevalent substance used other than smoking cigarettes was marijuana. So in looking at our data, we had 4 patients that have had a positive carbon monoxide test greater than 6 parts per million. And then you can look at the 2 circled data points here. One of the non-current smokers had a positive carbon monoxide test, and then 3 of the current smokers had a positive carbon monoxide test. And we'll go through this data in a little bit more detail to make sense of it. We had 8 patients that had a positive serum creatinine test, 4 of the not current smokers, and then as well as 4 of the current smokers. You can see the bolded outline around the 3. These were patients that also had a positive carbon monoxide test. So there was an overlap of positive tests for these 3 patients with a positive serum creatinine and a positive carbon monoxide test. This may be a little bit easier to understand. Let me see if I can move this out of the way. These are the same data points, just charted on this plot here. On the left hand is the carbon monoxide level in parts per million, and then on the bottom here is the serum creatinine level. The patients, the red dots are the patients that were the not current smokers, and the blue dots are the active smokers. You can see that the non-active smokers had positive serum creatinine greater than 3 nanograms per mil. And these I've labeled why they might have a positive serum creatinine. One has chewed tobacco, another one has chewed tobacco, e-cigarettes, and nicotine replacement therapy. So these are patients that were not smoking cigarettes, but they were consuming nicotine, so it tested positive. I wanted to point out this patient here, one of the active smokers who was also actively trying to quit, was on nicotine replacement therapy, and we'll never know when her last cigarette was for sure, but we do know that she was actively taking nicotine replacements, either gum or a patch, and also tested positive on a serum creatinine test. This is the same graph, but this is the graph that I included in the paper. The triangles being the current smokers and the circles being the non-current smokers. I wanted to point out that the reference line for positivity for serum creatinine is this red dashed line, The patients below the red dashed line had a negative exhaled carbon monoxide level, and the patients above had a positive exhaled carbon monoxide level. If you look down at the bottom, this is a chart comparing serum cotinine tests to self-reported smoking status. You can see that the serum cotinine was positive for 4 of the current smokers, and then I've highlighted in the red box the not current smokers. These are the 4 patients, which are the black circles on the chart above, that were using other products but were reported as not smoking. And looking at the serum cotinine test compared to self-reported smoking status, you can see that it has a very high sensitivity and relatively high specificity and positive predictive value. Now, when we look at comparing exhaled carbon monoxide test to self-reported smoking status, this is the test that we were most interested in. We can see that the carbon monoxide cutoff line, which is this red dotted line, that only 3 patients tested positive for this. These are the black triangles that you see above the red dotted line. All of these patients are smokers. The one patient on the bottom left, the triangle that I've highlighted in blue on the chart, this patient was trying to quit smoking and was on nicotine replacement therapy, and thus, even though had a positive serum cotinine, had a negative carbon monoxide level. The one patient I'll point out in green here on the top right of the table 5 that has an asterisk next to it, this was someone who is a non-smoker and did not test positive on serum cotinine, so they originally were not on this chart here, but I've placed them here for you now. This was one patient that was using marijuana so frequently that he was able to have an exhaled carbon monoxide greater than 6 parts per million. And then again in the blue, I'm pointing out that this self-reported smoker did not test positive. When looking at creating a test, you want to have a high level of sensitivity and specificity when you're using a screening test. And we found that if you combine the exhaled carbon monoxide test with self-reported smoking status, you could increase the specificity and positive predictive value. So simply by asking the patient, do you smoke? And when they say yes, we would count that as the test being positive. Either of these tests being positive, either a carbon monoxide or a self-reporting smoking status, would create a positive test, whereas they would have to have a negative self-reported and negative exhaled carbon monoxide test for the test to be negative. Using this construct, we were able to create a very highly sensitive and highly specific test that would be very easy to use in clinic. I'll point out that we had 16 patients that did have multiple tests using the exhaled carbon monoxide test. And for these 16 patients, there was perfect reliability, meaning the tests were the exact same the first and second time that we used them. This is our cost analysis, just showing number of tests on the bottom and cost of the tests on the left here. The serum cotinine test, at least at the VA, costs about $28 per lab, whereas the exhaled carbon monoxide test, you use a device that you purchase for about $1,000, and then the straws themselves cost about 15 cents. There's a maintenance cost of about $100 per year. So if you look at the green line along the bottom here, you can see these small bumps and increase in cost. Those are the $100, which I figured, you know, in a slower clinic, maybe over the course of 5 years, you would use this test 500 times. We found that there would be a cost savings of about $12,000 after around 500 tests, even including the upfront unit cost and maintenance costs over the course of 5 years. The strengths of this study was that it was prospective in nature. We had published a protocol to follow prior to patient enrollment. We used both exhaled carbon monoxide and serum cotinine, and this helped us differentiate between smoking and nicotine replacement therapy. And then we also collected tests at multiple time points to allow for retest reliability. The limitations, obviously, we had much smaller enrollment than anticipated due to the COVID-19 pandemic. We only had 55 patients to study versus the 250 we had planned for. There's also discrepancies in test results, such as that patient smoking marijuana that we had not really anticipated, but this allowed for confounding of our results. We did have non-uniform enrollment on a regular basis, leaving 89 eligible patients unapproached. And there was also incomplete laboratory workup that led to fewer patients for analysis. Our hypotheses, I think compared to serum cotinine testing, we found that exhaled carbon monoxide test combined with a patient-reported smoking status had equal sensitivity but higher specificity and positive predictive value. We found that exhaled carbon monoxide testing allowed for differentiation between active smoking and those on nicotine replacement therapy. And we also found that exhaled carbon monoxide testing is very affordable. It offers immediate results as compared to serum cotinine testing. So in conclusion, this test is useful as a screening tool for preoperative patient smoking status, at least in this pilot study from the information that we had. It's quick, it's inexpensive, it seems to offer very reliable results. I think this was a nice study to highlight the inherent limitations of both exhaled carbon monoxide and serum cotinine testing. And it highlights the complexity of some patients, maybe some who are in the midst of smoking cessation or on nicotine replacement therapy, where dual testing may be necessary. I want to give a special thanks to all of our team at the VA who helped me with this study. It was a lot of work to get going. And these are all of our PAs, medical students, Lynn Marshall and Marie Kane helping me put the paper together. And then a sincere thank you to Dr. Yu for funding the study. So thank you very much. I'm looking forward, and I have my notepad ready, Dr. Levy.
I have no comments.
I mean, that's really good, Sean. And I have to start off by saying, I mean, to do real prospective work and then at the VA, is kudos and all that you learned. I'm sure that you will very much appreciate Dr. Levy and other people's prospective trials in the future more, having seen just how complicated it is, even for a relatively straightforward investigation. Congratulations.
Absolutely. Thank you.
Great. Okay, so a couple things. The slides were fantastic. Presentation was excellent. The paper was excellent too, but the presentation was better. And my sense is that when you put together the PowerPoint, it flowed a little bit better than the paper. Okay, yeah. And I think you probably sent the paper and then worked on the PowerPoint after.
Correct.
So a couple of things. Let's just go through it. So in the abstract that you sent me, again, the purpose isn't clearly stated. So there should always be the aim of our study is, the purpose of our study is. You said, this pilot study evaluates. Okay, that's fine, but you want to put the purpose, the word either aim or the word purpose in there. There's no hypothesis in the abstract, even though on the slides, your purpose and hypothesis were beautifully laid out. Okay, but there isn't anyone in here. And then in the abstract where you said interpretation, I would just change that to conclusion. It could be a journal formatting thing. Mm-hmm. In the results, the most important thing for me is being able to catch patients, okay? And I used to do cotinine levels all the time.
Yeah.
And I found that it was really uncomfortable when I caught people, and it was really uncomfortable when they came back a day or two for their surgical listing appointment and they tested positive, and then I had to cancel their surgery, and then I had like 24 hours to fill, an OR slot.
Yeah.
And so over the years, I basically just had a conversation with them to say, I'm not going to check your blood. You have to take some responsibility. And if you're going to quit, you tell me you quit and you do, I have to take your word for it. But I'm going to know when I'm in the OR because bone has a different color in smokers and you can usually tell.
Mhm.
And number two, if you don't have a good result, you can't put the onus on me. And what I tell them is, if you're going to falter and have a smoke or whatever it is, just call me. I'm not going to judge you, and I'll defer your surgery. And we want them to be nicotine free for 6 weeks.
Yeah.
So one of the questions I had for you is, how many did you catch? And it was hard to tease that out in the paper. It didn't seem like there were a lot, but it would have been really great on the slide where you had the patient questionnaire at the initial consult, and then
Yeah.
you didn't get a patient questionnaire at the pre-op visit, and you didn't get a questionnaire at the time of surgery. That would have been great to add those so you could see how many people are bullcrapping you. Okay.
Sure.
Because that's what it's, because if nobody's I mean, if it's like a 1%, then maybe we don't need any of these tests.
True.
So I think in the global scheme, you want to show that, you're really catching people. And if people know that they're going to be caught, then they're going to have a much higher rate of either telling you they're still smoking or actually going through smoking cessation.
Yeah.
So when you have a conversation, say, look, I'm not going to put you through a blood test, but the day before your surgery, I'm going to have you blow into this thing. And if it's positive, I'm going to know you've been smoking, and I'm going to
Sure.
cancel your surgery. So those are the things for me that are really important. Okay, so and the paper was exceptionally well written. I mean, really, really well written.
Thank you.
Okay, so then you talk about in your methods section, right, that a cost comparison was done, but it's not in the purpose anywhere. I think it was in your slides, but it wasn't anywhere in the purpose. So you can have multiple purposes, just like you could have multiple endpoints, and you got to clearly state that in your purpose. In the statistical analysis, put a p-value in there, okay? Just, p-value of 0.05 was determined as statistically significant. Okay, complete data for 55. Hang on. Oh, in the paragraph on non-current smokers and current smokers, you've got a typo in cotinine instead of cotinine. I mean, that's something you'll pick up.
Thank you for reading through that all.
Oh yeah. The cost analysis data is unbelievable, actually. So you got to have that in your purpose, in your methods, in your results, in your conclusion. In the discussion section, I don't actually mind when people say, when they start with the aim of our study was, and then the key findings of our study are. My preference is, I've seen the purpose twice now. I've seen it in the abstract and I've seen it in the introduction. So I just want to know the main findings of our study are boom, boom, boom. And then if there's 3 main findings, then each one of those sequentially are compared to other data, or whether it corroborates or doesn't corroborate, or how it's different. Okay, so at the end, you should have a section that says conclusion, just like the one you have for methods introduction.
Mm-hmm.
And then I would start it in that where it says in our study, right? So there should be a subtitle. So there's the strengths of the study, and then there should be a subtitle conclusion.
Yeah.
I would get rid of the first part, the first sentence, just delete it, and then start it with, our findings showed that the ECO test was cost effective and produced immediate results, blah, blah, blah. And then the last sentence, it was a little confusing to me. I think you should have in the conclusion, just like you have in your purposes, the, this test worked well, the cost savings, and that this is an alternative to serum cotinine tests, or we recommend, based on this data, we recommend serum cotinine levels and ECO tests to, whatever. Now, didn't it say that the ECO only tracked for 24 hours? Did I miss that?
So the literature, some literature says 24 hours, some say 48. I think it's dependent on how much a patient is actually smoking, and I don't think we actually know.
So that's a problem, because if somebody has been smoking for 6 weeks and then 2 days before the test they stop and then they have a negative ECO test, it tells you that that's not enough, right? And the serum cotinine, that goes what, 4 weeks or more?
Yeah, much longer.
Right. So for me, I mean, I almost feel like you need both, and it would be real. So my recommendations for you are, you could present this as a pilot study, or you could, now that you've got everything, go back and get your 250 patients,
Right.
right? I
Right.
mean, I don't know if you have funding to do that, but if you have the funding to do it, to really make this study powerful, you've got a power analysis, you get your 250 or 247 patients, and then you really, you just beef up the whole paper.
Right.
But the problem is, if you only use the ECO, you don't know what they've done for the last 6 weeks.
True.
So you kind of need both.
That's a good point. I will say in the literature that I've read that the smoking habits of individuals that are smoking daily, I would be surprised if they can quit for 2 days. Maybe some of them
Yeah,
can,
right.
if
So
they can, then maybe they can quit longer.
yeah, maybe we got to convince them that test will track them all the way back 4 weeks.
Exactly.
But it'd be
you're
really interesting to know how many you're catching. Okay.
yes,
In other words, what's the difference between the patient reported questionnaires at all those time points
right.
and then what they're doing? Okay. Because then you're holding the patients accountable at every step. And I think they're gonna feel, okay, well, I better stop, or he's not going to do the surgery. She's not going to do the surgery. So
Yeah.
for me, that's the clinical relevance.
Yeah. Well, I really appreciate your remarks. Thank
Yeah.
you so much, Dr. Levy.
Okay. Great job.
Thanks, Sean.